Dr. Noel Collins first, who's an older adult psychiatrist with extensive experience in providing specialist care to older people who live in residential aged care. And Dr. Collins has a lived understanding of the current challenges and potential solutions for our safer systems of mental health care for older Australians, with a focus on rural and remote settings, and particularly later life depression and dementia. So Noel, over to you. Thanks very much for joining us today.
Thanks for the introduction, Christine, and also thanks for the invitation from Victoria and GANA. I should say that I'm on Menang Budja here in Conjarling or Albany, so I'd like to pay my own respects to Menang elders, past, present and future. I have a few roles here in WA. One of my roles is as a Director of Older Adult Mental Health throughout all of WA, which is a very big region, as you'd imagine, and also very, very diverse. So the needs of people up in Kimberley are quite different to the needs of people here in the Great Southern. Before I came back to WA, I was in the UK, and I've been really fortunate over my 25 years now of working in mental health that I've had excellent nurses, and I've been very, very privileged to have really great community nurses in particular, because I've been focused on community work. When I came back to WA 7 years ago and decided to go bush for a while because I needed a bit of an antidote to London, I've been really fortunate with the people that I've worked with here. So when I had the invitation to attend today, I thought that the best thing to do is really to talk about two community nurses that I work with here in the Great Southern, just to really illustrate how they are probably some of the best nurses, community nurses that I've ever worked with ever, in different countries, in different settings. So I think the first person I wanted to mention is, I'll use her nickname, which is Bubbles. And she is a solitary practitioner. She's a community mental health nurse that looks after a wheat belt town, about 8,000 people in total. It's a good 2 hours from Albany, where I am, and it's a good 3 hours from Perth. So she really functions as an independent practitioner most of the time. She's been in the job for about almost 30 years. And if you're walking the street of Katanning, barely 200 meters or so with Bubbles, you have to allow yourself extra time because she knows everyone in the town. So her knowledge of the local care landscape is exemplary, impossible to reproduce. She knows everyone and everything that's happening in Katanning, which is also really important when you're dealing with a town that doesn't have access to providers of care, for example, that Perth would have. So she knows exactly what's going on in terms of the care context, and that makes her particularly effective, I think, in her role. And what's really interesting is that she has been such a stable part of the community for so long that the Aboriginal patients that we serve there have great faith in her. And if a family in this town or a nearby town are experiencing a crisis, they'll often request her specifically because she's been a stable, continuous part of the service there. I think it's hard for me to even describe the degree of expertise that she has, and she's developed this over years of learning on the job. Her current kind of role doesn't really exist anymore. It's sort of the old enrolled nurse's role, but she is, again, one of the nurses that I admire the most in terms of the breadth of clinical work that she can do, and also dealing with some quite kind of complicated settings. One thing that I found very strange working here is there's always assumption that the care we're delivering outside of big cities is somehow a poor cousin of what you get in Perth. And I've always argued that actually, you know what, I think we deliver exemplary care. And that's been my experience of going to other regions such as the Midwest, because even if it's a smaller workforce, the community nurses provide, I think, just a gold standard for case management in terms of continuity. They follow their patients throughout a whole journey. They will step into a space when there's no one else that can help and check out, particularly GPs, for example. One of the other outlining towns has very unstable GP coverage, so we can't always discharge to primary care. That might be the default in Perth. So she steps into a space and yet somehow manages all the other things that are expected of her in terms of maintaining the increasing burden of, electronic notes and reporting. So it's a demanding role as well, which she somehow manages to do. There are particular demands that she also faces. I mean, I think one of I don't want to be sort of pejorative, but having the suicidal farmer who's older, who's starting to experience cognitive issues or frailty, who is adjusting to the fact that they can't continue in that farmer role indefinitely. And that often presents quite unique risks in terms of, assessing suicidation and managing that. But again, Bubbles manages that. Somehow she does. I would typically support her by coming up for a visit, once a month, really. Some of the other team members would try and go up and help her a bit more frequently than that. But because I've worked with her for 7 years and because I trust her, and I think this is the case with rural practice more generally, that if you know the people providing care have been a stable part of the care system for a while, you trust them. So if I get a call from Bubbles about a certain issue or she's worried about something, then I will be worried about that too. I won't interrogate her questions. Have you done this? Have you thought about that? If she comes to me saying, I'm concerned about, Mrs. Smith, and I'm worried particularly about this, and I think we should do that. I think the CAPA agreement in terms of what I think should be done is pretty high. It's quite rare that I have to suggest something new to her. I'm always looking for something because sometimes I wonder about the added value. But the vast majority of the time, I'm really just saying, yes, that's entirely reasonable. What can I do to support you to do what you need to do? My main worry with Bubbles is a worry that's shared amongst all of WA. I did some workforce mapping a couple of years ago, and over 50% of the non-medical workforce that deals with older adults is on the verge of retirement themselves. And so, she is irreplaceable. There's no way I can pretend otherwise. You would have to recruit, I think, kind of 2 younger nurses to kind of take up her role, to develop the expertise that and the trust as well that she's developed over time. So that is a particular challenge with this town, and is a challenge facing many other areas as well. I also just wanted to mention another community nurse that I had the privilege of working with, I should say, for the last 7 years. And she has stepped into a dementia navigator role, which I managed to get some funding for. And the program has been tremendously popular. It's been very, very effective. Because like Bubbles, she's been part of the care system for a while. She knows everyone and everything. She has good relationships with people with ACAT, Dementia Services Australia, other care providers. So that same level of trust that I was describing between me and Bubbles also exists between her and other people. And I think that's the magic of working rurally, is that it's a more intimate care setting, and trust is a currency. And I think it's a very good commodity rurally, when perhaps in contrast to metro, where systems and health service providers are bigger, and that isn't that sort of constant sort of working relationship. The other thing about, I'll call her Sarah, which is not her true name, is that her mother herself recently died at 100, and prior to that had been experienced dementia, as a carer. And so she has this sort of dual expertise of not only her credentials as a nurse, but this willingness and generosity to draw on her own lived experience of things. And I had to conduct an evaluation of the memory sort of service, and also the Dementia Navigator scheme. And part of the qualitative feedback from people who were receipt of the scheme was they felt that the advice she was giving was not only informed, but personal, and also very authentic. So I didn't want to talk too much longer, but I just wanted to flag those two examples, and I can think of many, many more over my career to this point. But again, if you'd asked me a year before I left London, what was I expecting in terms of the expertise of community nurses, I don't know what I would have said, but I can certainly say now that this group of people are just some of the most devoted, most experienced people that I've ever worked with, have a real investment in the communities they serve. Thanks very much.
Thanks very much, Noel. That's great. Now, there is one question in the question box, which you did mention, so we can also take other questions as well. But this one's from Susan Brownlow, who's saying, as you said, that clinicians often pivotal for the delivery of care services in rural areas, but what and how are you going to look to that succession planning when the workforce is so sparse?
I mean, it's a great question. I really wish I knew the answer to that. In WA at the moment, there is work to develop a statewide model of service for older adult mental health, because in contrast to other states, such as New South Wales, Tasmania even, this has been a neglected area for over a quarter of a century. This work has started, and we've had a number of consultation rounds. And when I'm presenting an introduction to this work, to the consultation rounds, I end with a picture of a Trojan horse, which really symbolises that I expect and hope that the model of service will comment on other issues such as workforce, because without that, the model of service won't exist. And I will draw on my experiences from working rurally to influence what I think is important, the vital ingredients for workforce. I mean, recruitment is one part, obviously, but retention is another. And I'm particularly mindful of sole practitioners like Bubbles and also Sarah, that we need to support people in more remote locations so they can support the communities they serve. So it's a bit of a long-winded answer, but I don't have it, but it is a critical issue.
Yep. Thank you. And I think the added complexity of there's only one person doing the job in the town, so there's not actually the scope to have another job with someone's learning and being mentored at the same time. So are there any other questions? People can put their hand up if they have anything immediately.
Excuse me, jumping in case other people would like to ask a question. Noel, do you see a place for a generic mental health for older persons practitioner to address the issues for workforce shortages in rural and remote communities? And have you had any experience of that?
So again, it's a really excellent question, and I think you need to be creative with tricky situations or wicked problems. So I think that's something that should be considered. With the dementia navigator role, one thing that I did try to do was to draw up a competency framework that would support the position, and that position was competency dependent and not completely allied to a person's role or their level. And that's what I think has been done in the UK, for example, and it could be done here. And I'm surprised that there hasn't been that focus on that, certainly in WA at least.
I just wondered whether not everybody will be familiar with the dementia navigator role. If Noel wouldn't mind just explaining that for us as well, and that'd be all my questions. Thank you.
So like you, Victoria, I worked in the UK for a good while, and one of the things that is different about the UK to here is there's a dementia strategy, and as part of that, the need for post-diagnostic support has been flagged in that. So the memory assessment pathway in the UK is owned pretty much by older adult psychiatrists like myself. Of course, neurologists and GPs and other clinicians have a role. And within that, the post-diagnostic support is provided by dementia navigators who, when I left the UK, were provided by Alzheimer's UK, like a non-governmental organisation. So the Dementia Navigator is someone that is available from the point of diagnosis that can help the person concerned and also their carers navigate the complexities of of support, both within social care, but in other respects as well. There's a real need for it in Australia as well. And there's some talk and realization that is important, because it's a terrible thing to have this condition diagnosed, but to be left with no support. And, I think that if people feel they've got someone who can guide them through the process of like ACAT, Alzheimer's WA, which is the equivalent organisation here, then a lot of that distress is gone. Carers feel held and they feel able to face things once they're aware of what the system of support is. And why on earth would anyone be an expert on that? Because it's taken me years to understand that myself, and I think that the systems are not designed to be intuitive or obvious. So I think there's a clear need for that. We've demonstrated a clear need for that here. I would hope that it gets picked up in other regions as well.
Thanks, Noel. I do think the navigator roles are increasingly important, and it just generally, I think, for aged care, not necessarily just dementia, even though that adds complexity. Liam McAden has put into the question answer. Thank you, Noel. Sounds very similar to the dementia link worker role in Scotland. 12 months of guaranteed post-diagnostic support for anyone diagnosed with dementia in Scotland. I don't think we're at that point in Australia, but I do think there's increasing recognition of the need for support post-dementia diagnosis, but also just to navigate our aged care system, which is quite complex. Okay, well, thank you very much, and we'll keep you there for a longer chat session after Aloha has talked to us.